And welcome to your webinar for OHT's Caregiver Strategies in Action, how Great River OHT is supporting integrated care through caregiver inclusion. My name is Melissa. Please note that your microphones have been muted and your video is off, but we encourage you to introduce yourself in the chat and to use the chat for questions and comments throughout the presentation. We will get started shortly. And we're very, very pleased today to have folks from OHTs across the province join us for the next hour to hear about all the concrete ways that your OHT can ensure that caregivers are integrated into your work. Well, we meet today on a virtual platform with people joining us from across the province. I'd like to take a moment to acknowledge the land we each call home. I'm speaking to you today from Tikaranto, which is located on the territories of the Anishinaabe, the Wendat, Neo-Wansayo, the Haudenosaunee, Mississauga, and the Mississaugas of the Credit First Nations. The area is covered by Treaty 13 with the Mississaugas. And as OCO team members, we're learning about the lands from which we work, exploring how we can be meaningful allies and how we can support the recommendations from the Truth and Reconciliation Commission. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our understanding of local Indigenous peoples and their cultures. I'm grateful for the opportunity to live, work, and learn on this land. And in particular, as we approach the National Day of Truth and Reconciliation, I'm acutely aware of how our systems benefit certain people and populations, and am reflective about how to challenge these systems of oppression and power from the place that I stand, especially when it comes to the access, equitable care, and justice in healthcare that Indigenous populations deserve. I also think about how I will continue to build my knowledge and learning beyond September 30th. Finally, we invite you to take a moment to reflect on the land where you are. And if you are not familiar with that, we will put a link to native-land.ca in the chat box so that you can explore this further. By the end of the session, you'll leave with an understanding of why caregiver involvement and support is critical to improving care and services across an OHT system, practical tips and an essential care partner program implementation pathway to advance your OHT goals with examples from Great River OHT, and then also actionable examples for your OHT to embed caregiver inclusion and support into existing deliverables and plans. So we are joined today by Tracy Crowder from Great River OHT, Judy Dancause from Cornwall Community Hospital, and Emily Go from St. Joseph's Continuing Care Centre. And hosting from the Ontario Caregiver Organization, we have Alison Kilbourne, who's the manager of the Essential Care Partner Support Hub, and myself, Melissa Nago, and an implementation lead on the team. I'll now pass it over to Alison.
Thanks so much, Melissa, and great to be here with everyone today. If you're not familiar with us, many of you are, I'll be really short and sweet. We, of course, exist to improve the lives of the approximately 4 million caregivers living in Ontario. We're a non-for-profit charitable organization funded through the Ministry of Health. Caregivers, of course, are at the center of our work. We offer free programs and services, both in English and French, to caregivers across Ontario, including our 24/7 helpline for caregivers to direct them to supports and services, especially local supports in their own communities, and supports they need for not only their care recipient, but also themselves. Our work also, of course, involves gathering insights from caregivers and engaging with caregivers in program development and design for our own programs and services. But a large part of our work also involves working with health system partners, and that's what brings us all together here today. If you can go to the next slide, please. Many of you have seen this model before, but to kind of make sure we're all on the same page and frame our work, really the work that we do at OCO with health system partners helps healthcare organizations, including OHTs, to implement what we call caregiver inclusive practices to improve patient and caregiver outcomes And we approach this work using our kind of three key pillars that overlap and influence each other. First is the identification and recognition of caregivers at point of care. Of course, including caregivers as part of the care team is a central focus, and then really connecting caregivers to support that they need for their own well-being. Of course, at the foundation of this work is how caregivers are engaged in the planning and design of any programs or practices that impact them directly. OCO offers large-scale learning events like this one, tailored education sessions for providers, tools and resources to support you in your work. And we collaborate with healthcare organizations across many settings, and including OHTs like yours, by providing support and guidance for caregiver inclusion initiatives across OHTs and within healthcare organizations. And we can, of course, work with you to connect caregivers to support. Next slide. I think it's always helpful to provide a bit of an overview of the topic, and so the next few slides I'm just going to provide a kind of snapshot of caregivers in Ontario, but also unpack what this looks like and why it's so critical for our work. As I mentioned, there's over 4 million caregivers currently, including young caregivers in Ontario. From every age group, with over half making up that kind of sandwich generation, including, I'm sure, many of us on the call. Almost half of care recipients are 75 years or older, and this is, of course, particularly important when we think about some of the population health approaches taking place in OHTs across Ontario. Next slide, please. So there's a number of impacts of caregiving, and I'm sure you've heard this before, but I just wanted to highlight a few things. The first is, if you can kind of push me forward, Melissa, as we go. The first is that kind of key piece of time. So more than 34% of caregivers are providing more than 10 hours of care per week. And this is particularly important because the amount of time spent on caregiving is significant, because higher time commitments are associated with higher levels of distress. So that's something to keep in mind. Next, work-life balance. Of course, 43% of caregivers have considered quitting their job to provide care. We have about 67% of working caregivers. So when you think about that large group and then that subsection, 43% considering quitting their job, that has a huge impact on our kind of overall society. And many caregivers do experience a loss of income and benefits associated with caregiving. Caregiving is expensive. On average, the out-of-pocket costs to a caregiver is just under $650 a month. These costs represent things like transportation, travel, accommodations, purchasing care or services, supplies, and even home renovations. 1 in 4 caregivers have taken out a loan or are using a line of credit in order to pay for care. So caregivers and the care recipient often co-reside and are dependent on each other's financial contribution. And I know we see this in many of the community settings that you're working in. But this is really important to understand the financial strain that caregivers may be under. Caregiving impacts the health and wellness of caregivers directly. 32% of caregivers say they're not coping well mentally or emotionally, and 22% report not coping well physically. So caregivers' plans and needs are often put on hold in order to care for someone, and that's intertwined with a lack of time for either self-care or taking care of their own healthcare needs. And that's really important when we think about the impacts of health on the caregivers themselves. Finally, in terms of personal relationships, caregiving has a huge impact on personal and family relationships. Caregivers experience the changing relationships, of course, with the person they're caring for. But really importantly, based on our last Spotlight report, 72% of caregivers say they're so burnt out, they're not sure how they'll continue caring for the care recipient. And 76% report being unable to enjoy their own activities of daily life. So these are really important impacts that are really important to consider the kind of big why around why we're all here and why this is so critical to the work of OHTs. Next slide, please. So I wanted to touch on, thinking about beyond the kind of impact on caregivers directly, but how caregivers then are interacting and intertwined with the healthcare system. And you probably heard from us previously about the kind of critical role that caregivers play. They're that invisible thread. They're often referred to as the quarterback, but there is an important gap that we're seeing when it comes to the value that caregivers bring to the system, and even to the immediate care team, and then the recognition that they have in the system, as well as how they're actually included or not included in care. So we see this gap where caregivers are, invaluable to patient care, but feel excluded from care, where they're amazing resources in terms of coordinating complex care. Their knowledge is relied on by healthcare teams, but they report not being fully incorporated into the care team. And then we know caregivers are often really the ones responsible for managing care, especially when patients may not be able to be in a position to do that themselves. But then caregivers are seldom asked what they need in order to provide the best care both for themselves as well as the patient. So I want you to keep that in mind as we're learning from our partners at Great River today. Next slide, please. This is also important to consider, and if you caught our last webinar in the spring, we talked about our Preparing to Care report and really the idea of caregivers and our changing healthcare system, with really an understanding that based on our aging population, as well as expected projection of Ontarians living with more chronic illnesses, we are faced with an unprecedented demand for healthcare. And that means an increase of pressure on family caregivers, and also an expectation that we're looking at more than 9 million Ontarians facing caregiver demands by about 2029. So these are all really important considerations, again, as to why this work is so critical. Next slide. So we know as OHTs that you're working towards many deliverables to improve care, including a readiness for integrated home care delivery, improved system navigation, and decreasing alternate level of care days. But all of this part of the system, caregivers are that kind of grease in the wheels, and what I really wanted to kind of highlight here is thinking about all of those interlocking pieces. So on the one hand, we have a system facing pressure with more than 9 million Ontarians facing caregiving demands in the next 5 years. We have caregivers, an understanding that caregivers are essential, but often not included as part of the care team. An understanding that caregiver distress is increasing and caregiver burnout continues to be a very, very large issue, but also an understanding that caregiver inclusion supports successful transitions and reduced hospital readmission. And of course, finally, that has a huge impact on patient health outcomes. They're impacted by both caregiver involvement as well as how well that caregiver is doing. So caregivers may be that invisible grease that keeps the gears moving, but if they're not taken care of, if they're not proactively included, the gears may come to a halt and break down, and that system may come to kind of freeze. And we're trying to think about ways to prevent that and ways to make that system work better. Next slide, please. So when we think about caregiver inclusion and what this looks like across OHTs, across regions, across healthcare settings. Before we hear from Great River, I want to kind of leave you with this reminder. We know that caregiver integration supports OHT's priorities and goals. And as you have all of those pieces on your plates, think about how caregivers intermix with those goals. So in terms of integrated home care delivery, caregivers support and manage that patient care in the home. In terms of population health management, caregivers are often providing that ongoing support and management for chronic health conditions. And when we think about system and navigation, caregivers are often the navigators who are navigating services for patients. So these are all really important considerations as you think about the planning and design work that you're doing in your own OHT. Finally, next slide, and before I pass it to Great River, I want to highlight a number of key strategies that we're already seeing happening across OHTs. So OHTs even now are hosting caregiver events, engaging caregivers in OHT planning and design, creating clear caregiver support pathways, and building communities of caregiver identification. So caregiver-oriented events mean things like appreciation days, caregiver information days. The meaningful engagement of caregivers means that caregivers have an increasing role in decision-making, building caregivers into those strategic plans. And if you can bump it a bit more forward, Melissa, two bumps. In terms of thinking about enabling caregiver support, we know that over 25 OHTs are currently pointing to OCO on their website. A number of OHTs are creating caregiver support resource pages and critically providing caregivers with resources at key points in care. And then finally, in terms of creating those opportunities for caregiver identification, we know that OHTs have work underway encouraging self-identification of caregivers and also enabling caregiver identification across settings. And that's where I'm really excited to hand it over to our partners at Great River OHT to talk about their amazing work that they have done. Over to you, Tracy.
Thank you so much, Allison. I'm very pleased to be here today with Judy and Emily to share our OHT work on this very exciting initiative. So on this slide, you'll see all the logos of our current partners. We currently have 2 community support service organizations, 1 long-term care home, all 3 hospitals within our OHT, and 1 organization that provides rehab, long-term care, and complex continuing care, engaged in supporting and expanding our essential caregiver program. Next slide, please. And who is the Great River OHT? Well, we're located in the easternmost point of Ontario. We border Quebec, this beautiful St. Lawrence River, and we go into parts of South Ottawa. So we're located in that little corner of Ontario. Judy, I'll pass it over to you.
So these are the key components of an essential caregiver program. This slide is from the Ontario Caregiver Organization. Allison already showed it to you earlier because it is so critical to the work that we're doing. There are 3 main critical points that helped shape our work, and that was identify the caregiver, include the caregiver as part of the care team, and of course to support the caregiver. Next slide. So as a collaboration, we had to agree on what is a caregiver and define it. And this is what we came up with. An essential caregiver is someone who is actively involved in the care of another person, such as a partner, a family member, friend, or neighbor. They are selected by the patient, client, or resident, or their substitute decision maker. They are unpaid. They are an advocate for the individual, and they provide ongoing support in a personal, physical, and or emotional way. A caregiver does not have to be the substitute decision maker or the power of attorney. Next slide. Tracy?
Thank you. So how did we get started? Really, the Essential Caregiver program was in our area long before the OHT came into existence. In 2017, the Cornwall Community Hospital launched their Caregiver Inclusion Program, which was a collaborative initiative inspired by the Cornwall and District Family Support Group and the Cornwall Community Hospital's Community Addiction and Mental Health Services. And over time, they established a family caregiver center at the hospital and laid the foundation for the Essential Caregiver program, which is now hospital-wide. Then in January 2024, the Frailty Project team of the OHT spent several months developing the parameters of an Essential Caregiver expansion, using CCH as the core center training site, and how would we expand to other partners. And as part of this process, we engaged other OHTs who were doing essential caregiver work to see how they were planning implementation, and that kind of helped us as well along our path. Next slide, please. So how did we engage our OHT leadership? Once the Frailty Project team, which consisted mainly of frontline staff and manager level staff, had developed the SMART goals and the logic model and the parameters of the project, we then took it to our leadership, which is called the steering committee in our OHT. So we completed a project team reports to steering committee, which is the top document you see. That report just includes high level information such as what partners are involved, what are the goals and activities of the project, what are the expected outcomes, and what is the impact on the quintuple aim, the CKIP, and our TPA deliverables. So this document was sent to the steering committee with the meeting agenda for their review. And then at the meeting, the members are provided with opportunities to add questions, ask questions, make comments, and get more information. Once the leadership table reviewed and approved the project, then we completed a pre-project evaluation that went to our quality education and evaluation table, which is the document you see in the bottom. These are just little clips from those documents. And that document actually delves deeper into the project parameters and specific questions about data and success metrics and how the project ties into specific quintuple aim, CKIP, and TPA deliverables. The QEE table reviewed the pre-evaluation, were able to ask questions, comments, and using their expertise as a table gave suggestions on how to, on additional data metrics we could consider or other things that they thought we could include within the project parameters. So on top of that, we also provide ongoing updates to our leadership table, at least quarterly, as well as updates in our monthly OHT newsletter and at project team meetings. Working group members were also expected to engage with their organizational leadership to keep them updated and informed on the progress and successes. And that ongoing communication across multiple channels in the OHT has really been key in engaging new referral partners. Emily, over to you.
Thank you, Tracy. So we actually began developing the model back in January of 2024. We then moved on with starting the staff training documents, finalizing all of that. Our original target was for September of 2024, and we were very close with launching officially in October of 2024 with our 5 founding members. Next slide, please. In terms of our goals for the pilot phase, we first wanted to establish that referral pathway. So that meant having a way to go about making those referrals. We did use CareGivers. And what we started doing was identifying some of our clients that could benefit from the program, opening up the dialogue with our caregivers, getting the consent form signed, and finishing off those referrals over to Judy at Cornwall Community Hospital. The second step was to start providing the education to our staff at all the partner sites so that they would be able to recognize and accept the badge. I'm wearing the lanyard and the badge, so are my partners here today, so that everybody would get a sense of what that looks like and what it means when we see individuals that are going about all of our sites collectively. And lastly, we wanted to start empowering our caregivers by providing that training. And the training is quite special. So not only does it cover the IPAC, but it talks about the role and importance of essential caregivers for their loved ones, but also while they're helping them navigate the healthcare system. As you know, a hospital stay can be very stressful and quite challenging from time to time, not only for the patient, but also for their caregivers who are by their side and often already very fatigued. Next slide, please. In terms of enablers, I don't think anyone can say enough about Tracy and her leadership. The OHT endorsement, of course, not only does it provide credibility, but our momentum, and Tracy was great at keeping us on track. For partner engagement, we were very successful in identifying champions for each organization. I can't stress enough the importance of being able to identify those individuals. Early adoption was quite easy because we had a few of our hospitals who had already implemented some programs for essential caregivers in different ways, smaller ways, of course, than the magnitude of this program now. But it did help in terms of being able to get some of that information from those different partners to get a sense of what things might look like for us here as we were transitioning. In terms of flexibility and adaptability, every member was great in terms of processing materials, working at adapting the materials so that it could be functional in each of their organizations. And then the OCO partnership was essential for us in terms of obtaining those resources. And Judy's support, of course, at Cornwall Community Hospital and getting that education started. So I just can't say enough about the team. I'll pass this back to Judy.
Thank you. So things that we had to think about. There was actually quite a bit. Did the hospital essential caregiver education align with the needs of the partner organizations? We had already started our program, as noted earlier by Tracy, in 2017, more on a mental health focus, but not exclusively. So we were in that, we'd already kind of started some of this. And was it still good? Did it meet the needs of all of our partners? What referral pathways would partners use to refer caregivers to this training and this identification? And now we're all just complimenting one another, but without Emily at St. Joe's, honest to goodness, the work that's done there and Care4 with their early adoptions, it was just phenomenal to send people into the program. And that, I think, has been part of our success. Would partners use the same staff training tools? And if so, what would they be? At its core, we have the same training, but each organization has customized it to make it suit the environment that it's being done from a staff perspective. What data did we need? We reviewed it all. One of the big challenges that we faced was consent, something that we really had to think about. Consent in healthcare, particularly with hospitals, has very distinct meaning. So what did we need? What did we need to do in order to protect our patients and still include caregivers and meet that line? So in the end, as a collaboration, at this time, we haven't solved all of that. Each organization still is dealing with our consents individually, but it is one of our future states that we're working towards, is to find a consent form that we could all use so that the caregiver and the patient or individual only has to sign once. Next slide. Excuse me. So who does what? Well, excuse me. To identify the caregiver, the referral partners are critical. Excuse me. Emily at St. Joe's, Care4, to identify caregivers because they're out in community, meeting with individuals in a different setting as opposed to the acute care facilities. Phenomenal. Including the caregiver as part of the care team, all of our partners will recognize the badge. And we are all working on improving all the time the identification of caregivers, particularly if there's a transfer of care from one referral agency to another. And finally, to support the caregiver, we have our education or I call it orientation of caregivers, where at the end of it, we issue the photo identification badges. For an acute care facility, that is absolutely critical so that this is the trigger that lets our staff know that we have authorization to include this individual in the care of this person. So the badge and wearing the badge is a really big part of the program. All of our partners provide additional organizational specific training if there's unique needs at St. Joe's versus Cornwall Community Hospital versus any of the other organizations that are our partners. So yeah, we all have a role and do different bits. Tracy? Oh, sorry, Emily.
Emily, yes.
Sorry, I'm happy to share our accomplishments. We now have officially 103 essential caregivers that have joined the program. We have, of course, those cross-sectoral partnerships that have been established. Of course, we have built a very healthy culture, I would say, where we're actively problem solving and troubleshooting back and forth as issues do arise, which has been a great, not only do we do that in meetings, but we're constant communication, whether it be by email or a quick phone call away if there's any issues that do arise. We do have that standardized essential caregiver training, which is being provided. Important to note that in-person piece has been rather invaluable, and frequently I will have caregivers return after the training just to say thank you in terms of the benefits that they've experienced just from having an opportunity to talk about their experience. The staff training programs as well, they've been standardized, they're ready to go. It's just a matter of changing up those logos, and we have that established referral pathway. What's also been helpful through CareGov is we do get that data collection, which has made it a lot easier. And we have some success metrics that are now in place through surveys. We've also created that comprehensive communication package. And most importantly, all of our essential caregivers are wearing their ID badges at all of the 5 partner sites. Next slide, please. In terms of phase 2, we are at the target now for fall 2025, hopeful for October to launch our phase 2. We have onboarded 2 new referring partners, which is another long-term care home at Dundas Manor, and also a new community support center, JDW Macintosh. We're also thrilled to be able to say that the Glengarry Memorial Hospital is now providing their training on site, as well as Winchester District Memorial. So that is very exciting.
So the goals of phase 2. So one of our goals is to establish the essential caregiver training at the other 2 hospital sites. As Emily said, we're aiming for the end of October. It has been pushed back a little bit because of staff turnover. So we have new working group members from both of those hospitals. So we said, oh, let's just take the time to do it right and get those 2 new members up to speed and able to do the training by the end of October. We want to, and the reason we're doing the extended training sites is because one of the first feedback we got from caregivers when we started offering the training at Cornwall Hospital was that they wanted to attend training closer to where they lived and or closer to the hospital where the person they care for might end up going for care. So we have a huge geographical area for OHT, over 4,000 square kilometers. And so it really made sense that to bring on the other 2 hospitals as training sites so that all 3 of our hospitals in our OHT will provide the essential caregiver training. We also, there were some concerns around if we expand to the other 2 hospitals to do the training, how do we know that training is going to be the same at all the hospitals? Because the working group had diligently reviewed the essential caregiver training offered at Cornwall Hospital. They all agreed on the components were appropriate around IPAC, PPE for their sector, for their organizations. So how do we make sure that that's continuing at the new training sites? So we decided to develop a training video to ensure that all sites are then providing consistent information on those key components. We also needed, since we have new training partners, we need new referral partners. So once we identified the training sites, we then started reaching out to some organizations around those training sites to become referring organizations. That was one of our goals. We also expanded, got caregiver feedback throughout it that they'd like more education and training, that they'd like more access to more resources beyond the Essential Caregiver program. So that also was a goal of phase 2. And so as part of our training video, it's the OCO resources are embedded through links and QR codes for them. And that is printed at the sites and they can take that with them. So next slide, please. So our accomplishments, well, we're expanding the training sites. That's one of our biggest accomplishments. New partners are coming on board. They should be ready to start referring to the hospital sites when the hospital sites are ready to accept and start the training. We've got the standardized videos completed in both English and French. And we are also have just finalized a common program brochure. So it's a brochure that can be handed out by any partner and publicly as well. So people can actually access the program directly at the hospitals and not have to go through a referral partner. So there's a page referral ability through our CareDev site on our OHT website, where anybody can just self-refer, and then they can also use these brochures to call the site where they would like to get the training. So over to Judy and Emily.
I guess I can go first. You want to go first, Emily?
Sure. So in terms of challenges, I won't speak to the consent part, Judy, we'll let you cover that. But in here in our area, because we also have a long-term care program, and the idea we had in terms of building into our procedure, and we are also starting to build the terminology into all of our policies to make sure that we have sustainability. But one of the challenges we've had is that those post-admission meetings are often focused surrounding goals of care and trying to prevent those hospital transfers and hospital admissions. And so some of our clinicians were just a little reluctant to do the referral, didn't really see as much of the benefit, in the sense that oftentimes we have substitute decision makers that are already involved with their loved ones in our long-term care program. So they didn't see as much of the benefit, whereas on our hospital side here with the rehab program, it's right off the bat, we had the regular referrals, and the buy-in was a little bit easier. So just something to keep in mind for long-term care homes. Otherwise, I would just add again that a lesson learned has just been the importance of starting those discussions with these essential caregivers, just taking a moment to highlight the work that they're doing, to recognize that we'd like to be able to identify them and provide support, has been the biggest lesson learned for me. Taking the time, just opening up the dialogue really has a big impact for folks. So that's probably the biggest challenge and our biggest lesson learned so far for me. Thanks, Judy.
So some of the challenges from a hospital perspective, we've talked on consent. That one will continue to be a little bit of an individual organization thing at the moment, but we are starting to meet as the 3 hospitals within our collaboration to see if we can find a common consent that we can recognize. It's not so much to write the consent. The issue is how to communicate it from one organization to the other, because it's considered personal health information and it cannot electronically be transferred. So there's some of those kinds of logistics. From an electronic point of view as well, one of our challenges was to figure out, considering each hospital or many hospitals do not have the same electronic health record, it was figuring out where should this live in the electronic health record? How does it become part of the transfer documentation? For example, if someone is admitted to Cornwall Community Hospital and then they're getting transferred to the Ottawa Hospital or to Alexandria, how does Alexandria know that Jane is that caregiver for that patient, so that they don't have to go through all of this and in a difficult time have to prove that they are a caregiver and are allowed to be at the bedside. So that was definitely one of those challenges. So we've made a lot of progress on that, and certainly more to come, because we don't have all the answers, and that's okay. I think another one of the lessons learned was it's not easy to schedule caregivers. It's not easy at all. So it's a matter of getting in touch with people, booking a time, letting them know that it's okay if they can't make it, but please let us know, and making that an easy process for them to do, so they don't have to feel bad or guilty. They have enough going on in their lives. So it might take 2 or 3 times before you actually have your caregiver show up for the training or the orientation session. That was definitely one of those lessons learned. It's not a one and done by any stretch. And I think those were the main ones. And it's really about, as organizations, always remembering that the caregiver is what we're trying. By supporting our caregivers, we're supporting our patients, because as acute care and healthcare organizations, we can't do it all. So it's been that really open communication amongst the group to get us out of our silos and working at problem solving as opposed to protection. Next slide, Tracy.
So as OHTs have new deliverables that are likely to stretch the OHT backbone staff, which is me, we're looking at ways to simplify onboarding of referral partners to sustain and grow the program. We developed a training site checklist, which is on the left, the document on the left, which is already assisting and being used by the 2 new training sites because they have new staff who are leading this work. And so they've given me feedback that it's been really extremely helpful. And then on the right side is a referral site checklist. So for all new referral partners, we'll send them this. It includes step-by-step everything they need to do to implement and become a partner in the Essential Caregiver program, including links to all the documents. So because it's really important that sustainability includes making sure that our documents are standardized staff training, standardized, our program brochures and other documents that we have are used by those new referral partners. And having this document actually gives clear direction to any new partners that come on, what they have to do. And so we're hoping that will help with sustainability as OHT's backbone we have to focus on other priorities in the future. Judy, over to you.
Sorry. So from a future steps point of view, we want to grow this. We want to grow this. It's so exciting to see so many of you from across the province who have joined us today. Healthcare is not linear. It's not, and it's definitely not singular. The patients that we have at Cornwall Community Hospital, we share amongst our partners here in our collaboration, but we also share them with the Ottawa Hospital, we share them with Kingston, we share them with so the more that as we grow this, we want to collect and evaluate data to make sure that the work that we're doing remains on point and remains supportive and helpful to our patients and our caregivers, but also to our organizations to help facilitate all of that. Identifying additional referral partners. The more people who refer in, the more we can train and orient and include. And again, promoting this program across the OHT. So, last slide.
Thank you.
All right, so we just want to say thank you to Judy, Tracy, and Emily for that presentation. That was really, really helpful information for our partners. I see some questions coming up in the chat, and we would like to open the chat now for your additional questions while people get started with typing that any questions that they might have for you 3. I'll start by asking a first question just to get us started. We're wondering, what have you observed or heard directly from caregivers who are essential caregivers or who are interested in becoming an essential caregiver at one of your sites?
Do you want me to start with that one, Emily? Actually, it's funny. The initial reaction that I get from caregivers is mixed. They're either very excited and thrilled that there's a program, that there's somebody who wants to listen to them, that wants to include them, or they're, why do I need to do this? I'm already doing this work. I'm really very busy. Like, those are some of those initial reactions. What I will say very consistently is by the end of the orientation program, they are so happy that they came. Like, I've had people cry. It has to be amongst the most rewarding work I've ever done. So definitely having that venue, providing them with support and resources on how to navigate some things within the hospital and our region from a healthcare point of view. But just having those interactions has just been, I'm going to say beautiful. I don't have a better word for it, but because it's not easy and some of them are going through a lot. Emily?
Thanks, Judy.
I would just say, just to add, Judy, if you're comfortable, it's just that you have your own lived experience as a caregiver within at least the organization where I am as well. So that I think that piece, just having someone who can relate to the experience of other individuals, is so much that part is invaluable, and definitely certainly adds to the experience. So that it's not just the formal support that Judy is providing, but a lot of the informal, not only from Judy sharing in some of her experience, but the other individuals that are sharing their own experience as caregivers is probably where most of the good value comes from. The IPAC's important, but I think that that part is really what individuals are sharing has the most meaning when they're coming back to the center. And everybody has a lot of pride in wearing the badge and wearing the lanyard. So it's really nice to see.
Yeah, I can imagine how that connection between caregivers can be very powerful. We'll go to a question in the chat. This one says, can you please provide more detail regarding what's covered in the caregiver and staff training?
Okay, I can take that one. So the caregiver training, the video includes things like IPAC, PPE, emergency codes, because they're standard across healthcare sectors, what it means to be an ECP, what could be some of their roles in a healthcare setting, being very general, because we're very cautious. You know, some things that caregivers might do in a hospital, they might not do in a long-term care home or in a community. So we agreed on more broadly what they could do. Also, privacy, the importance of privacy is also included in there. And falls. There's a couple of slides on falls. And then there's our last slide is links and QR codes to the OCO on top of that. So that's the standardized training, but they can, the hospitals will each also add their own like little individual training. Like at Cornwall Hospital, they meet in the family caregiver room. And so they talk a bit about hospital routines, you know, the colors that the staff would wear and what those colors mean, those kind of things. So each hospital will add what they think is pertinent from a hospital perspective on top of that standardized training. And for the staff, we really pulled from that caregiver training for the staff training. So it's just 8 slides. It's a small like PowerPoint that that partners can just pull into staff huddles or staff meetings. And it talks about why they're implementing an essential caregiver program, who is an essential caregiver, what training does the essential caregiver get. So that's important. So staff know that they've gotten the training appropriate to the organization. What does the badge look like? And actually a picture of the badge. And how can essential caregiver help in a care setting? So that slide they can also make specific to their organization and what can an essential caregiver do? And then how can staff support that essential caregiver? You know, by listening, by collaborating with the caregiver, you know, acknowledging and showing appreciation, things like that. So it's really quite a brief presentation.
Thanks, Tracy. That's really helpful. These next questions, I think they're more for Judy, although Tracy or Emily, you can jump in. So what is the frequency of the in-person training at the hospital for ECPs? And how do you manage individuals that face transportation barriers? Like, is a virtual option offered? And then also, what department of the hospital oversees the program?
Those are hard questions. So I am a mighty department of one that is currently doing this. I say that, but I have a great team of volunteers that are helping to support me. So I manage the volunteer program at the hospital. And I work closely with patient experience, Amy Malika, and our director of patient experience and quality and risk. So between the two of us, we had co-led the development of the program, and now I sort of maintain it. So I'm not answering these in the order in which they were asked. I run the orientation or the training about every 3 weeks. I sort of fit it into my schedule every 3 to 4 weeks. At first, I was doing it every 2 weeks, but that I found that very time consuming, and it was getting hard to maintain. So from a sustainability point of view, every 3 to 4 weeks is what I'm doing now. It hasn't actually, it has not come up that anyone has self-identified as having a mobility issue. And I don't know if that's because we are in the counties and it's always an issue. So it hasn't, no one has said, well, I can't get into the hospital, because I would have worked with them to find a solution to that, either to offer it virtually but even if we did it virtually, you still have to come on site. We don't have capacity for people to submit their photograph to create the badge. They have to come on site to get their picture taken. So there is that element or restriction barrier for folks, but it has not yet presented itself as being an actual problem. It's something we worry about, but it hasn't come up. So we're hoping that continues for a little while until we can accept an electronic photograph. I think I covered.
I think you got it, Judy. Thank you. The next question is, and just keeping an eye on time, we have a couple minutes left, so please get your questions in and we'll try to be really, really succinct with our answers. So the next question is, can you speak further to your referral process?
So our referral processes, we use CareGivers, and so the referring partner would talk to the caregiver, talk to the person they care for, get the consent signed, and send the consent along with a referral through CareGov to the hospital training site.
Thank you, Tracy. The next question is, are you connecting in with the PCN? Is this an identified need for primary care?
So this project actually started, we're at cohort 3 OHT, and our PCN wasn't really up and running at the time we started this project in early 2024. It is now very well established and growing. So we are keeping them in the loop and talking to them about it, but there wasn't that connection back at the beginning. We do have a clinical lead who's very engaged and who we communicate with regularly on this project. So.
Great. Thanks, Tracy. The next question is, what does staff training include? I think we went over that already, but what are the methods of delivery for this training?
So each organization decides that. They're meant, we have a newsletter article that they can use, and then we have the PowerPoint presentation that they can use at staff huddles or meetings, or if they want to do it through online, whatever they would like to do.
We used all three.
Right. And then there's someone who wants to clarify exactly what's on the badge. So, so if I understand, the badge is something that the caregiver wears to indicate that they're a caregiver for patient X, and that patient's name is on the badge as well?
No, just the caregiver's name and picture is on the badge. And then the organizations attach that person's name within the patient or client's record in their EMR system.
Great, thank you, Tracy. Are there plans to make the caregiver training accessible to staff and caregivers in other hospitals?
It already is. I'm a caregiver. I've done the training. Anybody can access it. They don't have to have somebody going to one of the partner sites. You can self-refer through our CareGov, or if you just hear about the program on our social media or anything, you can just reach out to Judy.
I am wondering if this person is wondering if it's hospitals outside of your region. So if they want to confirm that, please let us know.
We're happy to share.
Yeah, yeah, we are. Yeah.
Thanks.
Very
Judy.
happy.
Yes. Does everyone have to go through this program to be recognized? I'm thinking about dual caregivers who are well aware of IPAC, the system navigations, etc.
So yes, that is the ultimate question. They do have to go through the program. We've had a number of even people on the committee and whatever have you. They went through the orientation. We need consent, the authorization from the patient or that patient substitute decision maker, and then the orientation piece. Because we cannot presume that everyone will do things or know things depending on where they work or how they do things. So they only have to do it once, however. So if you, and what I have found is that being a caregiver is a little bit like a contagious disease in some ways. And once you become a caregiver for one person, it seems to spread amongst family members or close people. So if they've done the orientation and the training for John, they don't have to do it a second and third times. If they tell me that and I can demonstrate that that's the same individual, they would not have to do it again.
Okay, and I'll leave one more minute for questions. So I'll quickly run through the next few. Can you define what a referral organization is?
Yeah, a referral partner is somebody who's sending referrals to one of the 3 training sites. It can be any sector, really. We're hoping to grow it across our OHT.
Great. And was the training that your team and partners developed significantly different from what OCO has already developed? They're wanting to know if we do that same. If we do the same, if we need to make significant changes and contextualize it a lot to our region and caregivers.
That's a good question. I think we used OCO resources as part of our work, but we really built it off of what the Cornwall Hospital, the caregiver training and the staff training they already had. I would say the caregiver training they were giving was not changed a lot for the rest of the partners. It was very minimal. And the staff training, we just tweaked it to be more aligned with the caregiver training and so that they were kind of learning what the caregivers were learning. But yeah, so I don't think it would be super challenging to grow out of the hospital. It wasn't for us anyways, because the training was already aligning with what the other sectors needed as far as IPAC, PPE, and et cetera.
And when we started, when we started this in 2017, honestly, I don't know, in 2017, but shortly thereafter, it was based on the OCO work at the time. So these things are so intermingled, whether it came from us or OCO or, it's been quite collaborative and we have freely stolen regularly and routinely.
Thank you both. And just a note that OCO implementation leads like myself work really closely with these groups to co-create the training and consult on the training. So hopefully that answers your question. I know we only have 1 minute left, so I'm going to push us forward because I know we have a couple slides left. I'm so sorry if we couldn't get to your questions, but thank you, Tracy, Judy, and Emily for answering those questions. And I'll pass it over to Allison.
Thanks so much, Melissa. I'll be really brief. I think many of you might be familiar with our resources. I've highlighted a couple of here. We do have an Essential Care Partner implementation toolkit, which you can access on our website. We also have, of course, have a caregiver ID template, which Judy used the word stolen, but it's borrowed and really, invested in not recreating the wheel. So, and really happy to partner with you on many things related to kind of co-creation that Melissa talked about. And of course, we have the key practices for Ontario health teams that Judy highlighted earlier in the presentation. These are just a couple. And then if you go to the last slide, I just want to, in the last kind of 30 seconds, just leave you with a couple of key takeaways. I think as I listened to the presentation, I can't emphasize enough how important it is to build caregivers into your strategic plans, your quality improvement initiatives, working groups, OHT priorities. That needs to be central to driving this work. And engage caregivers at your planning tables. Listen to their unique voice and perspective. Even when I reflect on thinking about some of the phase 2 that informed Great River, it was informed by caregivers saying, well, actually, we want this. So that's critically important to listen to and be able to really build a program that is designed for and with the people who it will impact. And then, finally, look for those opportunities to identify caregivers across settings. Get messy, get into the weeds, and just push through. I think Great River has done such a great example of just not giving up, just pushing through, leveraging those partnerships, making those existing referral pathways work across organizations, being creative. And at OCO, if you go to the final slide, Melissa, we are here to help and support. Please reach out to us if you have follow-up questions, if we didn't get to your thoughts or questions today. Giant thank you to Judy, Emily, and Tracy at Great River OHT, and Melissa, who's been supporting them along the way. So thanks so much. Take care, everyone. Oh, and thank God, Melissa, don't forget, fill out our survey to let us know how this webinar was. Thanks again, everyone.